Okay, hello everybody. Welcome back. So glad to see so many familiar faces. Welcome to our new guests. I am Rebecca Berman, proud to be here and moderating tonight's conversation with our esteemed host, Glenn Grossman. Glenn Grossman is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff. Hold on, I'm going to press pause for one moment, Glenn, and mute everybody. Is there anyone else I forgot to mute? Okay.
I think that's good.
Let's try this. Okay, here we go. Okay. So Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology, forecasting, and advanced analytics with Bristol Myers Squibb, Sanofi, Novartis, Medicare, Medicaid, Veterans Health Administration, the Military Health Service, CDC, and other programs within the United States and abroad. All views expressed today are his own. So as usual, Glenn, can you kick us off by taking us around the United States and abroad and sharing with us your thoughts on how things are looking and what things with COVID-19 and what you anticipate how things will be looking like for the next few months with the vaccines and with the virus.
Yeah,
and let me go ahead and mute participants. And before you do that, just a reminder, number one, first of all, thank you to everybody who has sent in questions during the week. Glenn has been busy preparing answers to those questions. And if you have questions that should arise during our conversation tonight, please send them to me, Rebecca Berman, privately in the chat at the bottom of your screen. And I will do my best to weave your question into our conversation. And I will ask you to unmute. And if we're unable to get to your question in our hour together, Glenn will certainly answer your question next week during our conversation. And with that, Glenn, please take it away.
You do a screenshot. I took it.
Harry, I'm going to ask you to mute because you are not muted.
Oh, we're so sorry.
Mute.
All right, that's done. Great. All right, so let's go ahead and get started. So welcome everybody. I hope you had a great week. So I'm presenting on your screen. This is the number of people who died out of from COVID-19 out of every number within a certain region. So for instance, if you look in the bottom right-hand corner, 1 out of every 847 people died from COVID-19 in the United States in 2020. So that's a pretty large number. It varied, and some places were hit harder than others. So for instance, New York City was hit the hardest. New York City, 1 out of every 323 people died from COVID-19 in 2020. And New Jersey, where I reside, 1 out of every 437. There is somewhat wide variation, but all in all, the United States has been hit among the hardest in the world because of the management choices that we made. No epidemiologist would have thought that our country would have allowed ourselves for it to get this bad, that we would have just kept things open and not had enough stimulus in order to close things down for longer periods. And now with the new Biden administration, a lot of us have very high expectations. I'll go through some things. I'll start looking at just COVID, but then we can also talk about the vaccines, and we can also talk about the forecast in terms of what the next few months look like. All right, so let's take a look. Let me switch to this one. All right, so here, you're familiar with this graph. This is what we've seen in previous weeks. So what you see is that we saw for Thanksgiving and we saw for Christmas that there was a slight dip in the numbers. This was just a reporting issue. And what we're seeing now is a dip in early January. that's likely real. So it's probably not due to the just data issues. And this is really exciting. This is due, and well, we can go through this in a little bit more detail. We're also, for the first time for the surge, it looks like seeing the peak. And so this is really exciting also, that it looks like we're starting to come down based on the current stay-at-home orders in some of the states and mask wearing orders and that kind of stuff. But we're at such high numbers that this is the currently hospitalized numbers. We need to get this down as fast as possible, because you see these are people currently in the hospital. So even if we've gone past the peak, we're going to stay in really bad territory for potentially months. You see for the other peak that it would start, go up to the peak, and then maybe half of it or more was on the other side of the peak. And so if this is just half or more are going to end up after the peak, we really need to get this number down as low as possible. Similarly, with the death rate, you can see that the first surge, we had a lot of deaths because we weren't capturing the diagnosis very well. Then the second surge, there were less deaths. In the third surge, which we're in now, there have been a lot of deaths. That has not peaked yet, but it should peak probably within the next week or two. Now, another way of looking at this that's really useful is to see when the most recent, when the peak was, the most recent peak for each state. And one thing to notice is that all of these states, so New Hampshire, New Jersey, Delaware, all of these states had their peak for this surge in January 3rd. And it's been going down since then. Virginia is the only one that peaked this past week. And New York peaked the week before. So in terms of what we're looking at, you can see that a lot of states have already hit their peak. Now, the only thing that a lot of us are looking out for is, let me see if I can get this real quickly. Let me pause this for 1 second. All right, I am looking at the variants. All right, so we talked last week about the variants, the UK variant and some of these other variants that are out there. The B117 is the UK variant. This is the one, there's a bunch of variants, but that's the one that's the most concerning in terms of how contagious it is. And currently the thinking is that it's 50 to 70% more contagious than the other common variants in the United States. And so when you look at the spread of the variant, we're already detecting it in a lot of states now. So these have, and we're barely testing, we're hardly doing genetic testing at all for SARS-CoV-2 in the United States. And so that means that most of, when most people get tested, they're just getting a simple test. They're not getting their genetics analyzed for the virus. And so this is just the tip of the iceberg. And so even if in a state like Pennsylvania, only one person had a genetic test where they tested positive for this variant, it means it's just the tip of the iceberg and there's many more underneath it. And the states with zero probably have circulating, quite a bit of circulating the UK variant as well. So it's probably quite a lot. In terms of the total cases, so let me come back here. So let's go back to, let's say, the total that we were just looking at. So when we're looking at cases, you see that right now we're averaging around 220,000 cases a day. So right now, if there's only 80 cases that have been identified, that's hardly anything. It's not even going to show up as a blip. The problem is that is growing at an exponential rate. So even though we have the regular COVID epidemic, the percentage of the COVID epidemic that's the UK variant is going to get bigger and bigger and bigger over time, unless we stop it with shutdowns or more mask wearing and other kinds of things. The vaccine isn't going to be enough. The vaccine is just focusing on symptoms among the highest risk people first. We're not going to be able to get most of the population in the United States vaccinated within the next few months. And so as a result, this is really problematic, because if this is 50% more contagious or more, then that means that as our numbers start coming down for the common variant, that we might see another peak or another surge, let's say, not a peak. It's probably not going to hit as high as it's been, hopefully, but we might see another more persistent surge that extends out through May or June, which we would not have expected to see. And so that's one other thing to see. Another thing I wanted to look at was, Oh, let's see. Hospitalizations. All right, so I like looking at the how states are being hit relative to each other. So this allows us to compare states that are big versus states that are small, just in terms of how each state is being hit. And if it were me, based on the peaks that we just looked at, what I would do if I were Biden is I would have another stimulus, make it something that has a punch to it. So if he's looking at $1,200 per person or something, give it a punch, and with additional supplemental stimulus to small businesses and other people that'll be impacted by this, and shut down the country for another month or two, because you see that all of these states, there's too many people dying. If we go back to this for a second, the curve is out of control in this country. This is not acceptable. If we had shut down back in November, we could have prevented the curve from getting nearly so high. We could have prevented all of these deaths over here, or many of them. Now, if we have to wait for months more until this curve of deaths goes down, there are a lot more many more people that are going to die, probably over another 100,000 in the next few months, and that is unacceptable. And so if we were to shut down and dramatically reduce the number of new cases within just 3 to 4 weeks, this would turn things around very, very rapidly. Then we could start contact tracing and testing again, and we could use that to manage until the vaccines are more deployed. This is an epidemic that is out of control, and if it were me, that's what I would be doing. I would think we should shut down. Another reason for this is we looked at the IHME forecast before. One thing that they were looking at, I'm just going to jump ahead to this. Yeah, this was the key thing. So they had assumed, based on global responses to the epidemic and our initial response back in March and April, that once the death rate exceeded 8 per million, every state that hit that threshold would shut down. And so under their assumption, every state in dark orange should be shut down right now. And the fact that we're not is astonishing. This is not the country that I thought we were. This is not like a hurricane where people just grin and bear it until it goes through, that there's nothing you can do. This is something that we have control over if you choose to have a shutdown. And other countries are doing far, far better and not letting their people die. When we look at the total numbers again, we're hitting, this is on average 3,300 people every day on average over the past week. I mean, this is far more than died on 9/11, and that was one day. And this is every single day that we're hitting these levels or exceeding these levels. And this is, again, we have to reset our ethics. This is an ethics question. And we know what to do epidemiologically. This is an ethics question. So hopefully we'll have a surprise announcement from Biden within the next week or two about a shutdown. I don't know. It won't have to be long, but that's what I'm hoping for. We'll see it. We'll see what they do. All right. Now, in terms of let me go back here for a second. All right. So other things I wanted to talk about were okay. So here's what we're looking at on the global level. I think I saw something about Canada a little earlier. I'm not exactly sure what you're wondering. This is the case right there. They're going down some. They have been more aggressive than we've been in the United States in addressing it, and so they're not doing nearly as bad as we are in the United States. And so you can see that it's still burning kind of brightly in the southern hemisphere, which is unfortunate, because it still is warm weather down there for them. And so this idea of the seasonality they shouldn't be in such bad shape as we're seeing there. There is another variant that's emerged in Brazil. We don't know a lot about it yet, but we don't think it's as contagious as the UK variant, but we're not sure. UK, you see up here, is very dark, and that's because they have this very contagious virus that's on the loose there. And so it's just very hard to get it under control. They've been locked down for a while. but it's hard to get it under control. So that's why I'm saying before the UK variant really gains too much more steam. That's the reason I'm saying we need to shut down. So we'll see. I'll another couple months from now, we'll see if what happens and if we had made the right choice. All right, let's talk about vaccines.
Before we jump into vaccines,
yeah,
we have some questions about the variant and genetic testing, and your map showed just kind of singular tests. So could you just dig in a little deeper there? How do we, so like you have your 1, 4, so we're not really doing genetic tests. How do we even know that this exists? How do we know to the extent to which this exists across the country? And how do we know to the extent to which we should be even worried about it?
Yeah, so that's a really good point. So basically, there's genetic screening of the samples that are submitted, and they're randomly done across the country. The world leader in genetic screening right now is Britain. Well, it depends how you say it. If you're looking at the total number of genetic screenings performed by any one country, then Britain has by far the largest. If you're looking at the rate, so for instance, Australia is a smaller country where it has smaller number of reported cases. If you're looking at the rate, Australia is the global leader in terms of the percentage of those samples where they're doing genetic sequences on it. So in Australia, over half of all of the reported cases, over half of them actually have genetic sequences. This is great. They are on top of it. In the United States, we have been so overwhelmed. I mean, compare 28,000 reported cases to over 18 million, and we're not doing a very good job of testing. They're doing a much better job of testing in Australia. So when you're looking here, we've only done genetic tests on 1/3 of 1% of all the cases. So it's just the tip of the iceberg. If you see one person that tests positive, then you can multiply that by, what is it, 300 or so. That one person might represent 300 other people who are real positive, who have it. And so this is really poor in terms of this genetic testing. This is very likely something that that the new administration is going to try to ramp up to do a better job on, because if there's new variants that emerge and you're not doing sufficient genetic testing, then we really have no idea what's going on. It's invisible to us, and that's not a good place to be. So yeah, did that answer your question?
Yes, thank you. And we have another question. Rachel Scherzer, I'm going to ask you to unmute, has a question regarding going back to your map about shutdowns. And you had a really interesting map with the different colored orange about who makes these decisions and why. And Rachel's in Canada, and different decisions are being made in different countries.
So I guess in the US, I know historically it's been based on, state by state and the governor's deciding whether or not shutdown. I guess, was that a concentrated decision to not have the government be involved or the overall federal government? When could that change, or is there something preventing that type of a government-wide federal lockdown?
I don't know the exact rule on this. The federal government under Trump punted it towards the states to have them have responsibility. The question is, in a showdown where a Biden administration says this country needs to shut down, I don't know the limits of that authority. And further, regardless of what the previous limits might have been under emergencies, I mean, the federal government has quite a lot of authority under emergencies. It's almost certainly going to be challenged in our very polarized society right now. It would almost certainly be challenged to the Supreme Court. And with our new Supreme Court, with multiple Trump appointees, who has any idea where they would side in terms of what happens? All I know is that this is purely a management decision. The federal government has the power of the purse, regardless of anything else, and they might be able to say, if you want this stimulus, you must shut down, and which I hope something that they do, but I don't know what they're going to do. So it's politics, and I don't know how they navigate that. This is right now, it's been state determinations. but the federal government has more power than it's previously been exerting. All right, so yeah, that's where we are. These are a lot of states. This is not where we want to be. Anyway, let me go back to the first vaccines, and then to the. I'll go back to the forecast. First the vaccines, then excess deaths, then back to the forecast. All right, and then there's a lot of other questions I wanted to get to today. So since last we spoke, Israel has been doing astonishingly well. Over a quarter of their population has now been vaccinated. So they started with high risk, but now they're going deeper and deeper into the lower and lower risk people. United Arab Emirates also amazingly well, 19% vaccinated. Bahrain as well. UK really has been pushing very hard to get people vaccinated, particularly with the new strain. They've really tried to bump up. The United States is doing well, let's not say well, is doing better than a lot of other countries in Europe. But given the head start that we had, we spent all of this extra money to purchase the Moderna lots and lots of Moderna doses. That given the head start, it's surprising that we haven't made more progress. And so we'll talk about that in a little while. But this is where we are. This is the vaccination. Let me share the map. So on a global level, you can see that there's a lot of gray. So right now, the richer countries are prioritizing themselves, which makes sense. I mean, they're purchasing the vaccine first, but a lot of the spread is going to be occurring still in the poorer countries. And that means that if there's spread continuing there, then there's the risk of more mutations happening and more variants. And that could then break out and potentially interfere with some of the other vaccines and make it so the vaccines don't work as well. So we do need to not just vaccinate our own countries, we need to make sure that all the countries have coverage in some way. All right, this is vaccines. Now let's go back to excess deaths. We've talked about this in previous weeks, but I just wanted to jump back in real quickly. Currently, if we look at this way, the current best estimate of my current best estimate is that there are approximately 450,000. When all is said and done, I think in 2020 there will have been approximately 450,000 excess deaths due to COVID-19, either directly due to the virus itself or due to things subsequent to the virus. So for instance, the shutdowns leading to people losing their jobs and then developing severe depression or other types of things that were sort of secondary to the epidemic itself. But so 450,000 right now. It says 469,831. Let me come back up here for a second. So let's call it 470,000. If we look here, all right, so dark blue are the ones that have been reported. So you'll see this top line is 80,000 per week. This is the number of all-cause mortality, anyone who's died of anything. And so you can see that the orange line, the white space between the blue is the orange line is sort of statistically significant different. The blue, the average of the blue is, you can see, doesn't vary very much and is very, very consistent across weeks. The orange is just sort of for statistical significance. So when we looked at the two numbers, there was a range. I'm not really paying much attention to the orange because that's just for statistical significance. What's more important is the average across years, which is the blue. And so when you compare this, whoops, where did that go? All right, so when you compare this, you see that there's a couple of things. First is that so there's the first surge, the second surge, and the third surge here. The third surge, we know, was much higher in terms of total deaths than the first surge. We've already been hitting much higher peaks, yet those peaks you'd expect to be somewhere over here, and we haven't seen them yet. So that means all of these death certificates haven't been reported. This last week is January 2nd. So this is week ending January 2nd. So all of this white space up here is going to be filled in with death certificates in the coming months. It's just there's a long delay. So I believe when we add up all of the numbers within a couple of months to see all of 2020, it will be approximately maybe as much as 490, 500,000 above where we were. The problem is, let me go back here. So I think that this will probably be closer to 480, 490, maybe even 500,000 excess deaths. The issue is the way that this is being reported is the excess deaths relative to the average number of deaths from 2015 to 2019. The problem with that is that the number of deaths each year increases because we have a growing population, people are getting older, and so the total number of people dying each year actually is not flat. It's not an average that varies. It's more of a curve. It's a line that goes, a slope that goes up, a slope that goes up. And so a better way of looking at the excess deaths is comparing where you would have predicted we would be on the slope, which I should have made a drawing for this, I apologize, where we would have predicted we would have been on the slope versus where we actually are in 2020. And so when you do that comparison, I think order of magnitude, we're talking about 450,000 deaths or so. And so that's enormous. And this was even after all the shutdowns and everything we've been doing all year. In terms of the forecast now. So I said this is what we should be shutting down for. Before we go into questions, I just wanted to go and look at the current forecast. So I'm skipping ahead. All right, this is the current estimate for when people are going to start getting vaccinated, depending on whether we have a rapid rollout or just a expected rollout based on what we've been seeing over the last month or so. The green is what we would have expected, so that by May, we were expecting maybe 100 million people to be vaccinated. And so that's good if we can get it up that high. If we have a higher, more rapid approach, depending on what Biden is able to pull off, then it could be somewhere even higher than that. All right, given that, then what does the forecast look like? Because it's surprising that our forecast in terms of mortality actually doesn't change that much based on the vaccines. And the reason is we've already locked in a lot of what we're looking at. And this is what I was just talking about just a second ago, that if we've already gone past the peak, then that means all we're looking at now is how much of the other side of the peak we can avoid. And so if we're right about the peak of the deaths, maybe in another few days we'll peak there, how much of the other side of this surge can we avoid? And the problem is when we roll out the vaccines, it's not going to make a huge difference in the next few months. It will make some. Well, I mean, huge difference relative to 450,000. It will make some. In fact, IHME is estimating that around 50,000, I think, will be saved. So let's see where it was. Current situation. Projections in our reference situation. All right. So they think if rapid rollout of vaccine is achieved, we'll save 51,000 lives, and 37,800 lives will be saved if there's the regular rollout under the curve that we've been seeing so far, until by May 1st. And so I don't want to diminish this. These are significant. We've been looking at such large numbers. 37,800 is an enormous number of people whose lives are going to be saved. So I don't want to diminish this in any way. 51,000 lives could potentially be saved if we vaccinate more. And that's just through May. That's not even accounting for surges past May. And so this is really, really important. Yeah, every life matters. And even the difference between 51,000 and 38,000, if we can ramp it up, those are a lot of lives that could be saved. And so we definitely need to.
Absolutely, Glenn. Are you referring in this between these two scenarios here? Are you talking about the reserve in this rapid rollout? Are you referring to using the reserve? Could you define that a little further for us?
All right. Yeah. Let me go. That was a question that someone had brought to our attention too. Let me go back to that for a second. All right, so let's talk about the reserve. This is something that came up in the news over the past week. And so basically, this is Alex Azar. I think he just submitted his resignation. Thank God. Sorry to say. He was the head of Health and Human Services. So what is HHS? The FDA, the Food and Drug Administration, that approves all drugs and vaccines, reports up through him. The CDC reports up through him. All these health agencies report up through him. So he's a really powerful person that had a lot of control on all of this activity. He had communicated, and his team had communicated with President-elect Joe Biden. This is the first time that we heard about it. And he had said that there was a reserve of a huge, vast number of doses, of vaccine doses, that had been reserved so that people could get be sure to get a second shot, so that they were just giving out the first shots, but then the reserve would be given so that people could get their second shots without having to worry, so that we wouldn't have to have people getting their first shot competing with the people who are getting their second shot. And so in one sense, it makes sense. But as soon as the Biden administration heard this, they immediately said on January 8th, they immediately said, we want to end that policy and open up the reserve and make it so everyone can get the vaccine. And we have enough new vaccine coming in. We're not going to worry about the second doses. We're quite confident. In terms of the dosing schedule, so from both Pfizer and Moderna, what we've realized is you need to get the vaccine within the specified date. You can get it a couple of days early, a few days early, but if you wait a few weeks, it doesn't matter. So after your scheduled date, if you wait days or weeks or potentially even months, it doesn't give you the immediate protection. So the sooner you can get it, the better, the second dose, but it doesn't harm you for not having the second dose. You still should get pretty close to the peak benefit of the second dose when you get the second dose.
Can you say that again? Could you say that again? So let's say I get the first dose. Could I get the second dose 3 weeks later or 5 weeks later? Is there a difference?
So there's Moderna. Let me see if I can find this real quick. Moderna and Pfizer have different dosing schedules. One of them is for 3 weeks and one of them is for 4 weeks. Whichever they are, both of them allow you to get the second dose. Here, is this it? Oh yeah, so Pfizer is supposed to be given 21 days apart, and Moderna is supposed to be given 28 days apart. The key thing I was just saying is there is no maximum time between the first and second dose. There's a minimum time, so you're not supposed to get it less than 4 days earlier than the 28 days or the 21 days. You need to get it to wait at least of that period of time so that your body can respond enough so the booster shot is worthwhile. But after those two time points, there's no maximum interval. So theoretically, you could get the booster shot 6 months later, and the booster shot should still be that effective. Now, the one thing that you need to to understand is that the second dose is what you need in order to have the maximum benefit, the 95% protection. And it also is more likely to give you 2 other benefits. In addition to 95% protection from severe symptoms, it's likely to also give you more persistence, so it'll last longer in terms of how long the protection lasts. And then the third thing is that the second dose is powerful in that it's the same dose that in terms of the volume, but because of the impact that it has on your body, it has this additional benefit, this third benefit of actually making a huge number of neutralizing antibodies. We've talked about those in the past. The first dose will help with the symptoms. The second dose will help with the symptoms, but the second dose is what's really needed to help you from getting reinfected or from infecting others. And in fact, this was another question that I can jump to right now. And I'll come back to the question that we just had. Let me finish the question we had, and then I'll go to the question of reinfection. So does this answer your question, Rebecca, on the dosing? So there's no maximum interval?
Yes,
okay,
that's
good.
Very helpful. Thank you for clarifying.
You're welcome. All right, so next. So we were talking about Azar. So Health and Human Services, when they were meeting with the new presidential team to do the transition, they communicated to the transition team that there was this major reserve. As soon as the President-elect Joe Biden, as soon as their team said they would release it all, there was no reason to keep it in reserve, Azar immediately responded and said that was terrible. that they should not release the reserve, that it was short-sighted, that it was unethical. Azar said it was unethical to release this reserve. And then a few days later, 4 days later, Azar changed his mind and said, you know, instead of keeping this reserve, we think we're going to release the reserve. And so everyone was like, oh, great, we'll get the reserve opened even before Biden comes in on the 20th. So Biden's coming in this coming Wednesday. And so we were all expecting, based on this conversation that they've been having and publicly, that there was a reserve. And in fact, Azar, so Alex Azar, even not only did he keep saying that, then he further made this one other statement. And this is the big thing. So Alex Azar told the states that because that he was about to release this massive reserve and this expanded supply, he urged them to begin vaccinating adults 65 and over and other people with high-risk medical conditions. And so a lot of states paid attention to this. And so, for instance, I live in New Jersey. New Jersey just changed the eligibility requirements. And so it was previously more restricted only to long-term care facilities, to healthcare providers, and the very selective group. Then they said, okay, we're expanding eligibility requirements because of this reserve. And now what we found out is that there's no reserve. And so there wasn't a reserve. Even when these conversations were happening back with the transition team, there was no reserve back then. And so this whole conversation, this whole thing was, there was no reserve. So we're already getting the flow. The process is really screwed up. I fully expect it's going to be much more transparent and much more smooth. One thing I've heard is there has not been sufficient communication and collaboration between the military logistics people, who are, as I mentioned previously, are best in class for logistics around the world. They know they need to get, in a wartime situation, you need to get food, medicine, ammunition, people, everything all at the right place from around the world in different places, all at different times and different ways to get people all together. And they know logistics better than anyone. And we have them. And so they have been utilized, some in our current administration, but not enough. And so hopefully they'll be utilized. There'll be stronger collaboration with CDC and throughout the states. And so right now there's a worry over the next few weeks that the eligibility requirements in many of the states have been just communicated, that now people 65 and over can start getting it. I don't know if that's going to be rolled back or what's going to be happening, because there's not enough vaccine. There is no reserve to now start giving more people vaccines. So I don't know what that's going to look like. On Wednesday, we should start hearing a lot more. That's going to be the first day of the new administration, and they're going to hit the ground rolling. So I'm very enthusiastic. This time next week, we should know quite a lot more than we know currently.
All right, be careful what you say, Glenn. We might actually hold you to it.
I hope so. If, I'm going to be just as hard on Biden as I am on Trump, if Biden deserves it. I'm going to critically look at everything he's doing. If I think he's doing a great job, then I'll say it. If I think he's not, then I'll say that too. All right. You want me to go to the contagious question?
Yes, please do.
All right. So there's been this question of how contagious people might be after getting the vaccine. And so far we've had a little data that's released. It's not a lot, but Moderna released some of their data, and Oxford, so AstraZeneca's, that's the Oxford vaccine, hasn't been approved for emergency use in the United States yet, but it has been approved in the United Kingdom. And so we have some data released for this. And what you see is that there is still a fair amount of infections among vaccinated people. So this is the control group. This is the vaccinated. It's asymptomatic. And so this is good. This has a good benefit. There's a good thing about that and a bad thing about it. The good thing about having this asymptomatic, you can see among the symptomatic people, hardly any people with the vaccine had symptomatic infection. The vast majority was asymptomatic infection. The benefit of this is that it's asymptomatic and it's not going to put people in the hospital, and that's good. The problem with this is that once people get their first vaccine, it's not neutralizing, and a lot of people might be contagious and can infect people around them. If someone gets infected and has symptoms, then that alerts them to the fact that they've been infected, regardless of whether they've had a test, and they will know to go and tell everyone around them that they might have been with, their family, their friends that they might have been with over the last week, that they need to themselves go get tested. In contrast, if someone is asymptomatic and they don't know that they've been infected because they have no symptoms and they had the vaccine, they won't know that they've been infected. That means they might be infecting people around them, and the people around them, the only way they'll know that they were infected is once they have their first symptoms. And the problem is, once they have their first symptoms, then it's really hard, because sometimes some of them progress to severe symptoms very fast. If they knew that they might have been exposed and could get a PCR test days earlier, it would be much better for those people, because if they did test positive, they could immediately go and get the monoclonal antibodies and these other things. So this is a really dangerous period for us over the next few months, as a lot of people get their first vaccine when they could be contagious, and we need to worry about that. The second vaccine reduces that dramatically. There is still some that can happen. There's a reason for this. I'm not going to get too much into the immunoglobulins. There's different kinds of immunoglobulins. In the nose and mouth, it's a different kind of immunoglobulin than the general systemic immunoglobulins that we see. And so just because someone has a strong immune reaction for immunoglobulin G in the rest of their body doesn't necessarily mean yet, we don't know yet whether it also has a strong transmission impact in terms of having antibodies in the nose and the mouth. So this is still something we need to look at. All right, that's it for now. I think, do you want me to go on to reinfection? Because this was a similar type of question.
Yeah, before you do, can you just clarify about whether or not people can be contagious if what you just mentioned about, Rachel, maybe you can unmute and ask your question about your level of contagion. Sure.
I was just a little confused. When you say you could be contagious, is it because you've contracted the virus since you've had the vaccine, or does the vaccine create an amount of virus that could be transmitted?
Oh, yeah, I'm sorry, I should have been clear. So the messenger RNA vaccines, the Moderna, the Pfizer ones, the only ones available currently, do not make any virus. They just make a little bit of protein, no virus. So the vaccine doesn't make you contagious. I should have been more specific. It's if people get the virus and then they get infected, then they can become contagious. So I apologize. In contrast, there are other vaccines that are out there that are being investigated that do have virus, like the adenovirus, for instance. It's very different though, because really the adenovirus in that case is just a vehicle. And so they're putting the spike protein on top of this other completely different virus, and the adenovirus itself can replicate. But no, this is I should have been more precise. It's very specifically about people who are infected after they get vaccinated. But the problem is, because there's so much SARS-CoV-2 around right now, the likelihood of infection is not minuscule. People can still get infected, and so it's something that we need to worry about.
Worth repeating, the likelihood of infection is not minuscule.
It's very high.
It's very high.
To the point, let me go back one more second just to really punctuate this because of how important it is. So here's what we were just looking at before. Based on what I said on looking at the death rate, and where did it go? Projections and scenarios, that's not it. So this is no, that's pneumonia. Oh, did I already miss it? Where did I put it? Oh, here it is. This is the current death rate. Every single one of these, that it's so bad in this country right now that every single one of these states in dark orange should be in lockdown mode right now. The same as we were in lockdown in March and April, that's what we should be right now based on how bad it is right now. And everyone needs to recognize this, even though technically that's not the rule. For each of us who's hearing this, that should be the rule. We should be staying home as much as possible, masks on whenever we leave the house, physical distancing everywhere, and do not leave the house unless you really have to. Get your food ordered if at all possible. Really do not leave the house if at all possible. And do not invite other people into your house. do not do construction now. It's not a good time like to do construction. We should be under lockdown conditions for any reasonable way of looking at this right now. All right, let me go back to reinfections real quick. All right, so there are a couple questions. What will the next few months look like? So a lot of people were infected in March, April. People have been infected all year. We have the surge that we're currently going through. What does reinfection look like? So we're starting to get a lot more information about this. And so I wanted to spend a few minutes talking. We're almost at the hour, but here are some comparisons. So SARS-CoV-1, this was the original SARS that hit around, what is it, like 15 years ago, 20 years ago. This gave protection for 2 years on average. MERS, the Middle Eastern version, gave protection for around 34 months. Seasonal coronaviruses gave protection for only roughly 1 year. And so there was a major study that was just done, excuse me. And this major study was, it's called Siren. The results of it haven't been released yet, so I wasn't able to really dig in, but the people that did it were really top notch. And so I've looked at I've critically evaluated some of the data that they have released, that it was just very high level. And basically what they found is that by 5 months after infection, around 83% are still protected. So 17% after 5 months are likely to no longer be protected. And so that's not nothing. What this means, I mean, it's almost 20%, let's say, after 5 months. Now, what we know is that this is a curve. So the immediate 3 months, 2 to 3 months after the initial infection, people have their highest level of immunity. And there's really 2 kinds of immunity we should be talking about. There's one type of immunity that protects from severe symptoms, and then there's another type of immunity that protects from infection. And so this, we find, is what we're talking about is infection. And the reason infection is important is because if someone gets infected, then they can infect other people around them. Regardless of the symptoms, if they get infected and even if they're asymptomatic, they can infect people around them. The problem is when you have a curve like this, where at 5 months, 17% can be reinfected, that means that we're not hitting herd immunity. And so, in fact, when you look at the seasonal coronaviruses, I brought this out. Let me see if I can find it real quickly. All right, so when you look at seasonal coronaviruses, that lasts approximately 1 year in terms of the protection. And there have been no natural herd immunity for the seasonal coronaviruses so far. And so this is important, but that's not necessarily a bad thing. So let me talk to you about what this is likely to look like. Based on the reinfections, one other thing, I wanted to just go back to the other slide that we just looked at. One other key issue that they found is that even though 17% could be reinfected after 5 months, what they found is that only 30% of those reinfections were symptomatic, compared with 78% symptomatic the first time around, which means that the persistence of preventing symptoms lasts far longer than 5 months. And so this is good. So there's 2 issues here that we need to separate. Let me go back for a second. And so a big question here then is, well, what does this mean? Well, that's not the question. What does this mean over the coming months and years? Once people have gotten infected and recovered, what does it mean for them? Once people get the vaccine and are protected, what will this coronavirus look like? Is this something where we need a vaccine every year? Is it something that we need to, how will it evolve? And so when an epidemic starts infecting so many people, if herd immunity is not achieved and it doesn't get eliminated from the population completely, then what happens is it becomes endemic. And endemic means that it stays with the population unless there's some other intervention like massive treatment that knocks it out or in some way. But for all intents and purposes, it means that it will just become a regular part of the population going forward. There are a lot of coronaviruses out there. In particular, there are different kinds that have hit people. So there's around 7 coronaviruses that are in circulation in people. 3 of them are the highly pathogenic ones we've talked about: SARS, MERS, and now SARS-CoV-2. But there's 4 others that have been around for a while. In fact, let's look at this one. I put 2 different graphs in. I think this one is a little bit better. These other 4 coronaviruses, no one has hardly ever even been talking about them. In fact, we refer to them just by these codes, like, oh yes, human coronavirus 229E, or coronavirus NL63. Like, no one in the population even cares about them, because even though they're widespread and people get them all the time, they're irrelevant. They just cause the common cold. So who cares? Like, no one even knows about them except doctors and immunologists and epidemiologists, but the lay people don't care. And so the question is, will SARS-CoV-2 become something that's in one of this bucket where people just don't care? It's just a common cold. And instead of having a code, it's just, oh, remember back in 2020, how bad a year that was. And now it's just a cold. And so when you look at the history of these other viruses, and you might wonder, how can we know the history of genetic strains? There was no genetic screening back in the 1100s. And so what we do is, with genetic screening, you see mutations over time. You can work backwards to see what kinds of evolution, what that time frame was in terms of the evolution happening, and then you can sort of have a really accurate estimate on when that virus first emerged in humans. And so based on this is the approximate years or centuries, let's say, that they came in. So back in the 1100s, or when this NL63, again, it just causes a common cold, but it's just a human coronavirus. SARS was in 2003, MERS 2012, 229E was in the 1800s, OC43 again in the 1800s, HKU1 we don't really know, SARS-CoV-2 2020, 2019. But so let me show you. I like showing this one, so let me make this really big before we just get into a couple, 1 or 2 other questions. So this one, here it is. So these are lots of common coronaviruses. Some of them infect people, some of them infect other animals, but there's 4 main types of groups. There's the alpha coronaviruses, the beta coronaviruses, the gamma coronaviruses, and the delta coronaviruses. These 2 types of colds that affect humans are alpha coronaviruses, and these 2 types of coronaviruses that cause the common cold are beta coronaviruses. So the question is, will SARS-CoV-2 look more like one of these coded ones that are just the common cold, or look more like SARS-MERS? And so there's been some really interesting work on this, and that's what I want to jump into now. So first, looking at the common cold. So this one we're looking at here it's just using this code name NL63. It's just one of these human coronaviruses that are very common. This was looking at Kenya over many years. So through 2008 through 2014, no herd immunity was achieved. But what they found was that there was a lot of surges. Each year was seasonal, there were surges. And yet no one even knew anything about it. It was just causing barely any symptoms at all, just cold-like symptoms. And what we realized is that what's unique about this is that, and this is the big takeaway here, is that in the human colds, back in the what we were seeing here with the NL63, this tends to strike kids the most and give kids symptoms, but then spread the most and not have any severe symptoms. In contrast, MERS has severe symptoms in kids. And so SARS-CoV-2 is not like MERS, and this is great news for us, because it means when kids get it, for the most part, going forward in future generations, even though it's endemic, it's going to be just a common cold. The average age of first infection is probably going to be 2, 3, 4, 5 years old. Like even before they start elementary school, it's probably going to be quite common. One of these colds that they just get, no one even knows, because they won't know the history of how it impacted society before they got it, because if they're so young, it doesn't matter. And so what we're seeing with SARS-CoV-2 is the red line is that this is not like SARS-CoV-1, which had a higher infection fatality rate at older ages. And it's not like MERS. In many ways, it's very much like the common cold in terms of how it's looking. And so what we expect is that so if you look at this, so the two things I want you to look at, so this is the seasonal surges. See the pattern? It just goes up and down every year. The question here, and I apologize, this is so small. I'll see how big I can make it. So if you look at these surges here, the question is, how frequently will we have surges? And what people are thinking now, I think this is where the smart money is. It's not clear yet because not all the evidence is in, but right now the sum of evidence is suggesting that it's still weak. We don't know for sure, but the sum of evidence is suggesting now that based on the SARS-CoV-2, what's probably going to end up happening is that people will be reinfected. Even without getting vaccinated every year, the virus is going to continue to spread, and we'll have enough protection that we'll just be asymptomatic when we get it reinfected, or we'll have just minor symptoms, like cold-like symptoms. And so once we get it for the first time or get vaccinated, then we'll be protected going forward. And going forward, when you look at the ages, you can see that the age of infection, so this is the age, the color, pink is 0 to 10, all the way to purple is greater than 80. You see that the vast number of people eventually will be the 0 to 10-year-old group within just a couple of years after emergence. It's going to vary because the R0 that we saw varied a lot by state. So for instance, New York City had the highest R0 in the United States, and that R0 was close to 6. So that means in New York City, within months, once everyone's vaccinated or people have been infected naturally, it is very likely that this virus will only be perceived as just a common cold, and we won't have to see it again. Based on the number of new variants that are going around, we may need to be vaccinated again. So depending on the UK variant and these other things, then there may be a need for another vaccination if there's breakout that we've talked about before. But the most likely scenario as of now is that this is probably going to become an endemic virus that really looks more like the common cold that we don't have anything to worry about, even without getting vaccinated every year. So this one vaccine might be the only one that people need. We'll see. People are going to be keeping track. No one wants to relive 2020. And so a lot of people, there's going to be money spent to see if we need to get revaccinated. And if we do, we'll know about it. But for now, it may be the case that this one set of vaccines, the 2 doses, or with AstraZeneca, 1 dose, and some of these other vaccines, 1 dose, that may be enough that's all we need, and it'll just become a common cold. So this is great news for a lot of people, I think.
That is. And you know what, Glenn? We're going to press pause and we're going to leave it right there. We're going to hold on to that may be a piece of good news. We're going to hold on to that. We're going to accept that piece of maybe good news because that is excellent good news. We will absolutely accept that. Normally, we like when you deliver good news in the color green. And so this good news is in the color pink, and we will take it. Because earlier in the evening, your bad news was in the color orange. So this is pretty close to that, but we will accept it as the maybe good news. And definitely time will tell, but it's certainly, we will accept the fact that this is certainly pointing to the direction of maybe good news. So thank you for sharing the early indicators. Very, very exciting. Okay, well, thank you, Glenn, for sharing so much really, really useful information. We're excited to see what develops this week and beyond. Thank you to everybody who has submitted so many terrific questions during the week and during our conversation tonight. Keep them coming. Glenn, thank you for all of the hard work you always put into our conversations. And everyone continue to be safe, take care of yourself, good luck registering for the vaccine. And so terrific that so many in our audience have been able to already get the vaccine and already have appointments for the vaccine. And we look forward to being together with you next Sunday, same time, same place. Be well, everybody.
Thanks, Rebecca. Thanks, everybody. Bye-bye.